So, today's talk, well, did you read the title? No? Okay. If the virus scares us, our emotions will kill us. And it is a qualitative examination of how the LGBT community shapes the HIV treatment and experiences among gender and sexual minorities living with HIV in Tijuana. As we know, the 90-90-90 targets seek to reduce HIV incidence through increased testing, treatment, and viral suppression at the community level. And one of the policies and programs that can really help to achieve this goal, particularly in low and middle income countries, is providing universal access to ART. And low and middle income countries have already seen some important declines in HIV/AIDS related mortality with such programs. But in terms of the 90-90-90 goals in Mexico, despite having universal treatment, its impact remains suboptimal, with 44% of people living with HIV still not knowing their HIV status, 50% who have test positive with concurrent with an AIDS-defining diagnosis, and 40% of our persons who are eligible and know their status are not receiving treatment. The picture in Tijuana doesn't look much better, and similar to other regions in Latin America, Tijuana's HIV epidemic is disproportionately concentrated among men who have sex with men and transgender women, where the HIV prevalence among these groups is 20 and 22% respectively, and this is in stark contrast to the HIV prevalence among the general population of men and women in Mexico. As members of key populations in Tijuana, the available data from various epidemiologic studies and interventions suggest that 4% of individuals who are MSM and transgender who know their HIV status are not engaged on treatment. And this informed my Career Development Award, which really seeks to understand what the HIV treatment environment among key populations in low resource settings looks like, specifically working with MSM and purposely being inclusive of transgender women in Tijuana. And the study objective is to elicit key sociostructural determinants such as structural barriers, various community environments, and different types of social networks to understand how they come together to shape the HIV treatment environment among key populations, and use this data to develop and adapt intervention strategies that target the environmental context to improve HIV treatment outcomes. Today's talk will focus in on the community environment, and some of the community level factors that we thought we might observe are HIV providers' cultural competency for working with sexual and gender minorities, social cohesion within the LGBT community, as well as ways that HIV stigma, transphobia, and other experiences of violence and discrimination may shape HIV treatment behaviors. In the current study, participants were 18 years old or older, resident of Tijuana, and living with HIV. They self-identified either as MSM or as transgender women, and were recruited as clients of an HIV prevention or LGBT community-based organization in the Zona Norte, which is where the heart of the HIV epidemic is in Tijuana, or they were recruited as residents of local AIDS hospice. We've used qualitative research methods for this part of the study, specifically to get an in-depth, rich, more nuanced understanding of how these different environmental factors work together to really shape a treatment environment and people's engagement in care. We did in-depth interviews that lasted between 60 to 90 minutes and tried to stratify our recruitment by level of engagement in HIV care, such that we wanted to try to purposely sample individuals so we had good representation of people who were not engaged in care or on treatment, people who may be touching base with the healthcare system but not on treatment, and those who are fully engaged in care. And to respond to some of the reviewers' comments, our goal was not to achieve the ability to test statistical significance, and so our sample of 26 was actually achieved in order to receive saturation of responses. And what that really means is that as we did each new interview across participants from the different strata, what we were looking for is to see that we were no longer getting new information. And once we saw that we were starting to repeat information, it gave us confidence that with our 26 interviews that we had good representation of people's experiences of these different environments in the local context. Our interview guide had 8 open-ended questions on the different types of environments we were investigating and examined HIV stigma and homophobia or transphobia, respectively, from an intersectional lens. An example question is, I would like to start talking about your experiences living with HIV as a gay man in Tijuana. And from there, the interviewer would probe to explore how these experiences may have positively or negatively influenced their HIV treatment decisions. Interviews were audio recorded and uploaded into MaxQDA, where they were transcribed verbatim in Spanish and then translated into English for analysis. The transcripts were segmented such that each independent response to either a question or a prompt became its individual unit of analysis. And then we applied the framework thematic coding method, which allows us the advantage of both looking across at an individual's experience across the different environments, if we look across the row of our data, or looking at delving deep into a particular environment if we go down the column across participants' experiences, which is what we did in the current analysis. In the current analysis, I'll present emergent themes identified through iterative coding and memoing to characterize how LGBT environments impact HIV outcomes. And I'll provide exemplar quotes of what participants said that's reflective of the themes we saw across participants, even though for the sake of time, I won't read all of them. Our participants had been living in Tijuana for at least 2 years. Many described previously living in the US or had migrated from elsewhere in Mexico. All but one described themselves as being very familiar with the LGBT community in Tijuana during their time there. Time since diagnosis had a diverse range from 2 weeks to 25 years. And despite that range of experience, universally across participants, what we observed was that they described living with HIV was an invisible identity when themselves or others engaged in the LGBT community. 3 themes emerged depicting how community-level invisibility of living with HIV anchored in HIV stigma thwart optimal HIV prevention and treatment outcomes. So before I dig into the findings, I want to just review the stigma process that we observed across interviews, such that silence or invisibility around my identity as someone living with HIV was then seen as leading to increased ignorance or lack of knowledge about what HIV really is, driving increased fear around HIV, prompting increased stigma and discrimination towards those who are living with or believed to be living with the virus. And then as individuals living with HIV, if there's greater enacted or anticipated stigma and discrimination, that serves to reinforce the way I silence or keep my identity as a person living with HIV invisible within the LGBT community. And our first theme applies to how this process works to undermine HIV prevention outcomes. And this theme is titled, "The Consequences of Hiding Behind Condoms." Public engagement in the LGBT environments in Tijuana was perceived to be very liberal, particularly for MSM who had migrated to the city from elsewhere in Mexico. But there was a palpable lack of information in the community about what living with HIV actually looked like. Perceptions that HIV is something to be feared was described as dissuading community members from testing for HIV, and testing positive often led to anticipated or enacted social rejection from friends within the LGBT community if one's status was disclosed. It was emphasized that the normative discourse around HIV, when it is publicly discussed in the LGBT community, is that you need to use condoms to protect yourself, describing that as directly reinforcing that HIV is something to be feared. For example, one participant said, "HIV shouldn't be hidden behind condoms. They tell us, unless you want to burn, use a condom. On the contrary, living with HIV is not bad." The second theme was in relation to how the stigma process undermines HIV treatment outcomes, entitled, "If the virus scares us, our emotions will kill us." Silence and invisibility around living with HIV was discussed as having life and death consequences for community members. Information that HIV does not equate death was described as only available if one accessed HIV care after testing positive. Many very intentionally described fear as the real death sentence, not the virus itself, as fear is what kept people from accessing life-saving treatment. As one participant said, "The mind is what kills us more than anything. The virus exists, and if it scares you, you don't take care of yourself." Social support for HIV treatment also was not visible within the LGBT community, and the ability to see what life was like on HIV medications was perceived as something that would motivate engagement in HIV care. Our third theme really reflects how participants discuss the ways that you might disrupt the HIV stigma process in order to improve HIV prevention and treatment outcomes, entitled "Learning to Live and Love with HIV." Participants identified the need to visibly destigmatize HIV in the LGBT community, specifically by promoting life with HIV on treatment as normal. It was discussed that visibility of healthy men and trans women living a normal life with HIV would help to reduce fears around testing, but also help to model how to provide and receive social support to those who tested positive in the community. Having a platform that's not too gay to build social connectedness to others living with HIV was requested primarily by participants who did not describe having any other family or social support. Those that were able to access social support from partners and families often discussed wanting the opportunity to support others in the community who were living with HIV, and in doing so, they often reflected on their experiences of having lost friends who died from HIV in fear and isolation because they didn't have that form of social support. In conclusion, the current social normative discourse around HIV was seen to generate fear and undermine optimal testing and treatment outcomes in the LGBT community. Enhancing visibility and living with HIV, around living with HIV, as well as loving others with HIV in the LGBT community was perceived as necessary for promoting more optimal HIV outcomes. Integrating access to direct social support in a discretionary manner that was seen as something that would complement a more visible discourse around living with HIV as a normal, healthy lifestyle. In terms of future directions, the data support the use of social media campaigns within the LGBT community that aim to shift the normative discourse of HIV from something to be feared to something that's a normal part of life for many healthy MSM and trans women. Images that model how to live healthy on treatment and how to love and support others living with HIV as romantic partners and as friends could provide better visibility and reduce HIV stigma. Social media campaigns that provide confidential social connectivity to other MSM and trans women through anonymized mobile technology platforms might allow individuals to both seek and provide social support around HIV testing, disclosure, and linkage to treatment. Such platforms and campaigns may complement the use of home-based HIV testing, which was recently legalized in Mexico, helping to facilitate a more timely diagnosis and improve 90-90-90 targets among key populations in Tijuana. So, thank you for your time.
Are there any questions? Sorry.
Hi, Laramie. Thank you for that wonderful presentation. I have two questions. The first was, could you explain to people why you introduced yourself with your pronouns and maybe talk a little bit what's on the agenda here? It lists everyone's pronouns.
Oh, it's on the program. Okay, great. First of all, thank you to CFAR for being responsive and listing everybody's pronouns. The reason that I say my pronouns as I introduce myself is to normalize that process and open the door for individuals who use of pronouns may not be the ones that you would choose for them just looking at them. So people who may be gender nonconforming or transgender, it normalizes the process of introducing who you are and what your pronouns are so that people can talk with you respectfully.
Sorry if I surprised you with that question. So the thing that I've noticed, and this is with mostly my young adults who are Latinx, MSM, we talk about the idea of double disclosure, that maybe they have come out and share that they're gay with friends, but I think families are the big issue.
Yeah.
But they would never, ever share with families that they have HIV. The first part was traumatic enough. I always wonder what kind of education we can do for families, because the response I get is, bring your mom in, we can talk about it. Oh, she wouldn't understand it. This is, an old school person. Is there something with all of this that you can think of where we can engage families as well?
So from our narratives that we have, it reflects the experience you're talking about, right? Very dramatic experiences. If they disclosed that they were gay, not disclosing their HIV, very, very rarely would they say, I'll tell them I have HIV and not that I'm gay. But what you saw is the people who were more vulnerable and asking for that social support, it was because they had had those negative experiences already. Now, these data don't speak to how we might change that, but what I would suggest is someone who's old school needs to talk to mom who's old school, and that the program needs to be delivered through those social networks and systems in order for it to be received in a way with support of their peers who they're afraid are going to judge them, right? I think it's a very important issue to look at. Unfortunately, my data don't speak to it. Yeah.
I had a question about experiences in healthcare settings and if that came out at all in interviews and how their experiences in healthcare settings might have differed from the community.
Yeah, so I'll just repeat the question real quickly. So the question was about healthcare settings and how their experiences in healthcare settings might have looked differently from their experiences in the LGBT community. And the reason we're not, did not include that in this presentation was one, 12 minutes, but two, pretty universally, people's experiences with their HIV care or in the HIV care clinic were positive. They were generally very surprised that it was positive, that the doctors received them well as someone who was an MSM or someone who was transgender, if you're talking about the HIV care system, which is separate from the general health care systems. Narratives that were around use of the general health care systems were tragically discriminatory. So, I mean, I can give you an example of, so, okay, you're looking like, what do you mean? So for an example, a gentleman went into the hospital. This story will be probably a similar narrative to other people who work in Tijuana, had an abscess on his foot, discovered he was HIV positive, was kicked out of Hospital General to just basically die on the street. That's what he thought was gonna happen. And an extended family member happened to run into him and be like, no, we're not going to leave you here to die. We'll take you home, like, whatever, you're gay, like, whatever, we just won't deal with that right now, and work to get him connected to the AIDS hospice, where he was receiving HIV care, where he started receiving it, yeah. He hadn't been there very long, so he was still getting stabilized, I believe. But yeah, ideally would be no longer needing. But in his story, he described how during his time there, the two people on either side of him had died. So.
I had a quick question. I was really struck by the quote that described living with HIV as not being a scary thing and not being that bad. And to me, that seems a very positive thing for individuals living with HIV, but a very difficult narrative in terms of prevention. And so I was wondering if you could speak to that, because it has a very kind of complicated nature to me.
The complicated nature being that we want people to have a certain...
We often portray HIV as being scary and hard to live with and difficult, to promote use of condoms and other prevention strategies. So what is the kind of difficulty of normalization of living with HIV, but also using that as a
still wanting
strategy?
people to have protective behaviors? Yeah, I think that's a difficult public health balance across the board. But with regards to HIV, I think that's, if it's keeping people from testing, from knowing their status, from getting on treatment, we've tipped the scale way too far. And I don't think that in reducing fear in that message and replacing it with more factual information, like living with HIV will change the way you live your life. But if you're connected to treatment, it's not going to end your life, right? And that's where people really need to be empowered to make their personal prevention decisions, not keep away from this thing because it will kill you, which translates into keep away from everyone with this thing because they will kill you. That would be my response.
Thank you.
Yeah.
In the example you gave about the gentleman who was kicked out from the Hospital General, did he mention at all what the hospital told him of why he had to go? Was it because they said they weren't equipped for HIV infection, or they were afraid that he'd infect other patients, or they were just afraid?
It was along the lines of contagion fear. I mean, I can draw the actual quote for you. I don't have it memorized, but it was definitely contagion fear, like, and at which, leads to a feeling of lack of deservingness, dehumanization.
Thank you.
Thank you so much, and thank you to all of our speakers, Dr. Smith, Borgos, Gaffin, and Jane. It was a really interesting session, and thank you all for staying until the very end and for all of your engaging questions. Dr. Smith is going to...
The other Dr. Smith.
The other Dr. Smith. Yeah, give Laramie a round of applause. Thank you. Okay, I have a few announcements. My pronouns are he, his, and him. Thank you for reminding me. One announcement is an advertisement. Dr. Solomon is giving another talk tomorrow. We get as much talk out of him as we can at High Rounds, HIV and Global Health rounds. Maybe it's a little false advertising, High Rounds. But please join us 8 o'clock tomorrow morning at the AVRC. If anybody needs directions, they can ask me or probably many people here in the room. It's also a webcast, actually, so you can watch it from your pajamas. Third thing I want to bring up is that we're hosting, this CFAR is hosting the 2020 National CFAR meeting, and we need help. One of the big things we're trying to come up with now is what is our theme going to be for the 2020 National CFAR meeting. So put your thinking caps on. Let me or any of the core directors or Liz, any of the staff know any great ideas. We're also looking for entertainment ideas, big fancy people who might be willing to come and do some entertainment for us would be great, or speak or whatever along those lines. The other one is a big shout out to the cores. We talked a little bit about the BAM core today, but we have other great cores in terms of PEP core and genomics and sequencing and translational virology, et cetera, that offer lots of services at discounted prices, so please look us up. The other one, don't forget our developmental grants. We just had big submissions, but we have twice a year, and also the international pilot grants. Then I want to thank, as any good paper should do and every good talk should do, is have acknowledgement sections. So I want to thank all our speakers today. I want to thank our opening speakers and all of our moderators. They did a great job at keeping everybody in line other than me. And then I want to thank our Bauman photographers and our own visual media group for all their work today and making us look pretty, other than me. But I appreciate the effort. I also want to thank again our San Diego Admin Corps and our HIV Institute for all their work. And then finally, thank everybody here for their kind attention and questions. So stay dry.